Lisa Schwartz from McMaster in the Ethics of Military Medicine Research Group. And before we get started, I think that it's important to kind of bring home the kind of challenges that healthcare professionals in the military specifically experience. So I'm just going to read a brief excerpt that is a bit paraphrased from one of our participants. I had a patient that came in and it gives me chills even thinking about her. 90% full facial burns. Her face was so mutilated that I couldn't even tell where her mouth was. And it was just devastating. This woman was just moaning and we had to send her out to die. Our commanding officer at the time said, no, she has to leave. We can't provide care. It would be 3 nurses every shift. I understood his rationale, but he was being a logical person to make this decision, but it was a huge stress to have to let this woman go out and know she would die in pain. There was no way she was going to survive. Am I an advocate for euthanasia? No. But we don't have to deal with that really in Canada. But in her situation, there were no good outcomes. We have patients that wake up and say, why did you keep me alive? And in many cases, I felt very understanding of this perspective. Because in a country where we want to believe that things can get better, but it's already so bad, we have to be logical, and that is a huge stress for nurses working here. So the issue that I am seeking to address is the idea of military healthcare professionals, or MHCPs, who work abroad in a context of crisis, and they often experience moral distress. However, while there's a lot of civilian literature looking at moral distress, the literature in the military is still fairly limited. I just wanted to briefly go over some terminology. A moral dilemma is a situation in which one must choose moral imperatives that are both ethically justifiable. There we go, that's a little better. So a moral dilemma is a situation in which one must choose between moral imperatives that are both ethically justifiable. However, when one moral imperative is chosen, another is transgressed. Moral distress occurs when one believes they know the morally correct action to take in a moral dilemma, but they feel powerless to take that action. And that is because of a barrier, specifically. And a moral action choice is the actual action or direction that a healthcare professional in this situation believes is morally correct in a moral dilemma, and that's the action that they really strive to enact. The experience of moral distress is still being defined in the literature. Right now, the literature broadly describes it as an experience of intense suffering for a person. It's characterized by different papers as feelings of resentment, sorrow, low self-esteem, shame, helplessness, frustration, anger, misery, grief, powerlessness, compromised integrity, dread, guilt, self-criticism, lack of team cohesion, feelings of abandonment by their organization, and emotional exhaustion. There's also been established connections in the literature from moral distress to burnout, depression, anxiety, compassion fatigue, as well as things like reduced job satisfaction and high turnover rates. The objective of this paper is to take the current model of moral distress and to apply it to a broader range of military healthcare professionals specifically. The most up-to-date model that I had to work with was designed by Major Bradshaw as well as other authors, and that paper hasn't been published yet, but it specifically focused on designing a model that represented military nurses in the Canadian Forces, their experiences. So my paper and my thesis addresses the questions, which aspects of the model do our study participants support, and which aspects do they indicate may benefit from revision or expansion. And I also incorporated an interdisciplinary literature review that was actually called for by Bradshaw, and he argues that by incorporating different disciplines, we can have a better picture that better reflects what the experiences of military healthcare professionals are. So I don't want you to have to pay attention to all these little boxes. I'm just going to briefly summarize what the model describes. So in the blue, you can see this is where an individual encounters that initial moral dilemma. And then they consider their internal ethical codes, the external factors and influencers, and they make that moral action choice. They make their decision of how they want to act. And if they don't encounter a barrier, then they're fine. They don't experience moral distress. However, if something blocks that moral action choice, that's when moral distress is experienced. And Bradshaw argues that moral distress not only impacts the individual, but it also impacts things like the team, the chain of command, and the overall organization and integrity. As far as what the individual experiences, after encountering moral distress, Bradshaw argues that individuals go through this resolution process where they try to make sense of their experiences and integrate them and really grapple and struggle to understand what has happened to them and what that means for them. And this influences actually their perceptions and their experiences of future incidents with moral dilemmas and with moral distress. So this study recruited a variety of military healthcare professionals. We had physicians, nurses, and medical technicians, and they were all from the Canadian Forces, and the majority of them served in Afghanistan, Bosnia, and Haiti. We conducted semi-structured interviews, and the goal of these interviews was really to let these healthcare professionals just talk about their experiences with moral dilemmas, to really just share and open up. And the idea of the questionnaire was really to just allow and probe and ask them and help them translate and share that experience. The analysis was all done qualitatively using in vivo 10. We coded on hierarchical node systems, and we used an approach by Miles and Huberman that incorporates both deductive and inductive coding. So we started with a preliminary code book that was based on the interview guides and as well as the literature review. But then we continuously did this ongoing inductive analysis where we incorporated emerging themes that came out through the literature as we coded. And to make sure that we had internal validity still and we maintained that, we had ongoing meetings and discussions to really discuss what these terms that we were coming up with, define what these themes were, and place them appropriately in this hierarchical structure. After all the merged data was coded and all of their stories and themes were pulled out, I compared the data that we pulled to the actual model designed by Bradshaw and tried to pull out where it supported and where it indicated challenges. And I also included an interdisciplinary literature review to kind of support the directions that the emerged participants described. This is just a quick picture of what coding in vivo looks like. I'm not sure how many people are familiar with qualitative data. The preliminary results are very interesting, actually. We found that there was support for several aspects of Bradshaw's model that actually haven't even really been included in the civilian models yet. The first was the influence of the unique environment on and how it impacts all aspects of struggling with moral dilemmas and with moral distress. This was really depicted by merged participants, and they described how the deployed environment really increases your likelihood of encountering a barrier. And this has to do with things like resource challenges, cultural and social challenges. All of these stresses that arise naturally in the deployed environment can make these barriers more likely to appear. We also found support, and participants indicated some support for this idea of a loop back. And that really comes from psychology, and that was incorporated by Bradshaw, this idea that encountering a moral dilemma and having moral distress is not a static experience. It's something that's dynamic, and it impacts your future experiences. This is not an isolated event. As well, Bradshaw incorporates resolution processes, and he draws on psychological stress and coping models from the literature. And we found that emerged participants also really indicated that resolving the moral distress to them was equally as a part of the process as encountering that moral distress. It was a very intrinsic part of this process. I'm just going to read a quick quote that will kind of describe the unique environment specifically. Sometimes they have difficulties accepting the realities around them. And they'll seek to compensate by wanting to order MRIs and save every child and look for subspecialist help when you're actually in the dirt looking for people without limbs and with no food to eat afterwards. And so people would have difficulty coping. And sometimes it gets frustrating because it takes 2 weeks to get an MRI. So you just have to adapt to your environment. And people who can accept change and accept that things are going to be limited are fine. But people who have a fixed belief system about how the world should be, they have problems. As far as the preliminary ways in which the model could be expanded. There's two major elements that came out in our data, and the first one was really that the experience of moral distress is very progressive. It's cumulative. It's not something that is static. And our merge participants describe how that initial experience of moral distress really changes and evolves as they process it. And it really depends on whether or not they resolve it or don't resolve it. It can take a completely different form. So I argue that the model should be expanded to include and in some way this concept. And this was also supported by the literature, especially in psychology, that found that, and the research in ego depletion and the idea of cognitive resources, we have a limited quantity of these resources. And doing active processing, such as trying to resolve a moral dilemma or introspecting and trying to reconsider things, it uses up this limited amount of resources. And this means that if you're constantly experiencing these barriers, you might not be able to process as quickly and these resources might be essentially used up in a short time. And that brings to the second point, which is the idea that I believe that a crisis state should be included in this model. I think that it's important to recognize that there's a point where people don't have the ability to cope anymore. They're not able to maintain that normal functioning. They're not able to continue to cope. And there's a point where they are depleted. This also incorporates research from philosophy into the idea of moral damage. And this is just the idea that if somebody experiences a barrier to their moral action choice, often they might start to think that it's actually them that is the problem. Instead of considering the extended context and how that impacts their decisions and how that impacts their chances of encountering a barrier, they start to see themselves as the bad thing in this situation. They start to identify themselves as bad or immoral. So I think that it's important to include that concept too in that experience. The second way that we found that the model could benefit from some revision is the idea of this resolution process. So Bradshaw describes the resolution process as made of two components. First is situational resolution, which is the struggle to understand one's emotions, relationships, and ability to function as nurses and individuals. And he also describes self-reflection, which he defines as reflecting to gain meaning and to provide justification for one's actions and those consequences. And while our participants supported these ideas and these concepts, there was an underlying theme that came out, and it was this idea of controllability that really came out, that it's understanding when to act and when not to act, what is controllable and what is not controllable. So I argue that it might be beneficial to reconceptualize situational resolution and self-reflection on this element of controllability. So I've redefined situational resolution to be acting on the controllable elements of a blocked moral dilemma to the best of one's ability, and self-reflection as the considering and acceptance of the uncontrollable elements of a situation that leads to a blocked moral action choice. And this is also incorporates, it's not a new idea, this idea of controllability. This is something that's well established. It's looked at in adaptivist theories in psychology, moral development theory, in mindfulness theory, in virtue ethics and feminist ethics, and it also incorporates one specific important concept from philosophy, which is the idea of systemic bad moral luck. And that's the idea that your likelihood of encountering these barriers, in a perfect world, they would be 50-50 or less, ideally. But some contexts, they make these barriers systemically come up. And so some people working in certain contexts are just much more likely to have their moral action choices blocked and experience moral distress. So I'm just going to read a quick quote that describes this idea of controllability. Well, I just convinced myself that's how it had to be. I practiced medicine exactly as I was trained and as I would in Canada until I couldn't, and then I didn't, and I believe that. So if you can't, then it's not your fault anymore. But that seems to be, maybe that's it. I don't feel personally responsible, you know? When I had to choose person A or B, that had to happen. That was not my personal responsibility. We made the right decision under the circumstances, but I didn't create the circumstances. And if we had not been there as a team, it would have been so much worse. So we were making things better, even if it wasn't the 100% solution every time as we would inform Canada. And just as I finish up, I just wanted to read one more quote from another one of our participants. Some of the choices kind of fringe along the College of Nurses, your code of ethics, but if you can go home and sleep at night, then it's all right. It's a good choice. And as long as you comply with the military so you don't get charged. But as long as you can go home and sleep at night, then you've made the right choice, which is not always the right choice. But if you can sleep at night, then it's the best you can do. Thank you very much.
Okay, so we've got a few minutes for questions for Jill, and then when we're around the those, we can proceed to general discussion. I don't know.
Yeah, I think so. The presentation is very good at that. It's a common problem that we have in terms of treatment, the whole area of moral dilemma and moral injury. And I was wondering if you had an opportunity to review kind of the literature that's in the military context called moral injury and International Center for PTSD. Review it in 2012.
Yeah, I completely agree. I think they're so closely related. And there's this issue right now in the literature where this issue of moral dilemmas, moral distress, moral injury, all of these issues are coming up in different but related fields, especially related to the helping professions. And the problem is everybody's coming up with their own description of what this looks like, and there isn't really consensus yet in the literature. So I completely agree. I think that moral injury is a huge component. I've used it in my literature review, and I've used it to inform a lot of these recommendations for the model. So I completely agree. Thank you.
Any other questions?
Just waiting for the mic.
No.
All right. Did you consider screening for PTSD, depression, and anxiety? The only reason I ask is because often, certainly with PTSD, there's moral injuries that can coexist. And if you're looking at moral injury, then perhaps it would be interesting to see if PTSD or depression or anxiety are there, in particular in terms of the first excerpt that you read regarding the burn victim. That's pretty horrific, and that could be classified as a trauma. But then if you add in that moral dilemma, and if indeed the person was thwarted, if they can't sleep at night, then it might just be interesting to gather those data as well. Is that something you considered, or could you maybe, as it's ongoing?
It was definitely considered. Nobody was screened for mental health issues. But what did come out in the data is that a lot of people who wanted to have these discussions about their environment, a lot of people, they revealed in their interviews that they had been themselves diagnosed with PTSD or compassion fatigue or burnout. So a lot of these issues, and it just shows how related all of these issues really are. So I completely agree.
And especially too when you had that one point where the person's views of themselves changed, that they could be mad or something. Certainly that would fit with the negative alterations in cognitions and mood that you see in PTSD, for example.
Exactly.
More? Sure.
Thanks for an excellent presentation. It seems to be that someone experiencing moral distress is probably not going to be very effective in the field. We learned from Zimorsky that they're likely to have 3 times more likely to have suicidal ideation, for example. So it would seem to me that going from the streets of Toronto to Afghanistan to some aid station, you have to recalibrate your moral compass, and that medical behavior that's not acceptable in this setting, urban setting, would have to be acceptable, like making these tough choices and neglecting someone perhaps in favor of treating someone else. So it would seem to me that we would, to prepare our people, we would have to either teach them how to recalibrate their moral compass in some way, or we would have to identify those that cannot recalibrate and not send them there.
I think that it's a really important issue. I'm not exactly sure how it can be addressed. I'm just starting to get into this field, but I think that a lot of the work that's being done is really important to learn prevention and then also treatment afterwards.
Well, I'd like to join me in thanking Jill for her presentation. We've got some time for a general discussion.